Narmada's influence on him illa his influence on Narmada theriyadu.
Thank you, madam.
Good.
Sir, live ஆயிட்டோமா செக் பண்ணிட்டீங்களா?
Yeah, you're gone live.
Thank you. First time. So
start
பண்ணிடலாமா?
இன்னைக்கு அமல் சார் தான் இன்னைக்கு chairperson.
Okay. Of course, yes, of course. So sir, நீங்க அப்படியே சோமசுந்தரம் சார் ஹோஸ்ட் ஆக்கிடுங்க. இல்ல
எனக்கு நான் மொபைல்ல இருக்கிறேன்.
நானும் மொபைல் அமல ஹோஸ்ட் பண்ணிடலாம். நான் மாத்திக்கிறேன் அமல். நான் வீட்ல ஜாயின்
நானும் மொபைல்ல தான் இருக்கேன்.
பட் நான் வீட்டுக்கு வந்தோடனே மாத்திடுறேன்.
நோ ப்ராப்ளம்.
திருமுருகன் சார் அமல்ராஜ் ஹோஸ்ட். நீங்க இருப்பீங்கன்னா நீங்களே ஹோஸ்டா இருந்துருங்க.
இல்ல நான் உங்களை ஹோஸ்ட் ஆக்கிட்டேன் ஆல்ரெடி.
சரி. Okay. So shall we start?
Yeah.
Okay. Thank you. A very
good evening, sir.
Good evening, sir. Welcome, sir.
Good evening, sir.
Good evening, sir. A very warm welcome to everybody. We are all very eager to listen to yet another interesting series of Wow Wednesday and listen to abdominal X-rays now, a different shift from what we have been listening for the past 3 weeks. So as we proceed, I request Dr. Rajkumar sir, our treasurer, to kindly say the pediatrician's prayer.
Thank you, Narmada. Pediatrician prayer. Grant us the quality of holistic healing. May we humbly realize how privileged we are in being bestowed with the ability to alleviate suffering. May we be emissaries of health, learning, charity, love, peace to all children and their families, irrespective of status and creed. Give us the wisdom, understanding to change the things we can, retain the good, and accept within reason the things we cannot change. Grant us your blessings, grace, and mercy in all situations, at all times, and amid all people. Thank you. Over to you, Narmada.
Thank you, Rajkumar. Thank you so much for the same. Now I request our IAP Tamil Nadu State President, Dr. Somasundaram, to welcome all the dignitaries and the delegates who have joined on the platform. You're muted.
நீங்க மியூட் ஆயிருக்கீங்க.
Yeah, now it's okay.
So thank you, Dr. Narmada, and thank you, Dr. Rajkumar, for joining here, and welcome our Vice President, Dr. Vishwanathan sir, our EB member, Central IAP EB member, and chairperson for today's session, Dr. Amal Rai sir. Welcome you all for this yet another exciting session on of Wow Wednesdays initiative, that is the White and Black Wednesdays, the session 4, which under the convenership of Dr. S. Thangavelu. So he has done all the groundwork for this White and Black Wednesday series, and he has also taken the 2 sessions, the last 2 sessions, which was a marathon 90-minute session, which was live in YouTube and has taken more than 3K views in the past 1 week. So thank you, sir, for again. Thank you again for being here on the 4th week also. And for today, we have 2 interesting sessions by 2 pediatric surgeons, or renowned pediatric surgeons of the town, Dr. Nandini Madam and Dr. Rahul. So we'll be hearing from them on the interpretation of abdominal X-rays, because we, as pediatricians in an emergency, we should be knowing how these X-rays to be interpreted and those things. And as usual, the Dr. Nandakumar, our the coordinator, and Dr. Sri Priya, they are going to coordinate this session. So welcome Dr. Nandakumar and Dr. Sri Priya, and all the delegates who are here for yet another session 4 of the radiology series. And we'll hear from them for the next 60 to 80 minutes. Thank you. Welcome.
Thank you so much, Dr. Somasundaram. Before we start the program, I request Dr. Thangavelu sir to say a few words.
Welcome both the surgeons. They have the brilliant knowledge of a pediatrician and the skill of a surgeon. So we have both. Over to Dr. Amal Raj or Nandakumar. Thank you.
If Dr. Manohar sir has not joined us, I would like to... Dr. Manohar sir? Yeah. Okay. He's our academic coordinator and chairperson of the academic.
Tirusar is there. Tirusar, you want to say
Dr.
something?
Tirusar,
பாஸ்
yes.
எதுவும் இல்லை, நம்ம கேட்க நல்ல விஷயங்களை கேட்போம்.
Very
Okay,
well.
fine.
Okay,
Thank you.
thank you.
Aman, over to you for moderating this session.
I
We
think
have Dr. Raj.
I think Nandakumar will start and introduce
Yes.
Amal, right? Yeah.
Dr.
Amal will.
Nandakumar, over to you. He's a
Good e-
coordinator.
Good evening, all of you. I'm happy to introduce my good friend Amal Raj. He was my college mate in Madras Medical College, and he's a close associate of me for the past 3 decades. And he has got a lot of leadership qualities, and he has been a EB member of Chennai branch, and also he's now at present representing the Tamil Nadu as central EB member. And he was also the vice president of IAP Tnsc. I welcome him, and over to Dr. Amal Raj to moderate the session.
Thanks, dear Nanda, my brother, for those kind words. At the outset, to thank the IAP Tamil Nadu State Chapter under the leadership of our dear Somasundaram sir, our past president Rajendran sir, our president-elect Dr. Tirumurugan, our vice president Dr. Vishwanathan, our SS Dr. Narmada, and treasurer Dr. Raj for the good opportunity. I would like to thank our convener of the program, Dr. Tangavelu sir, the co-host coordinators, Dr. Nanda, and Dr. Sri Priya, for the wonderful opportunity given to me. At the outset, as we all know, usually we'll be celebrating the weekends of every month. But once this program got introduced, the Wow Wednesday series, we have started. The interest for Wednesday has generated, the interest and the curiosity for Wednesday has actually increased among all our state friends as well as in the national arena also. And also we have today 2 wonderful speakers, 2 excellent pediatricians, the pediatric surgeons today, Dr. Nandini and Dr. Rahul, to throw light on a very interesting subject. That is, it's the abdomen is, the many of our seniors used to say, it's a Pandora box. It is a box which is filled with a lot of puzzles and lot of illusions actually. So to throw more light on the subject, the series is named as White and Black series. But I think we have got 2 excellent speakers who can make this series more colorful and make it a colorful series actually. So I welcome the first speaker, Dr. Nandini ma'am actually. So Dr. Nandini, as we all know, she is the group head of pediatric surgery at Rainbow Children's Hospital. She has authored more than 20 chapters in textbooks regarding the pediatrics, pediatric surgery, pediatric nephrology, as well as the pediatric emergency medicine. She has written more than 15 articles in various index journals, and she has more than 30 presentations to her credit in both national as well as in the international conferences. She is also been awarded the prestigious VBR Gold Medalist and Gold Medal Award in the year 2015, and she is also the recipient of the RK Gandhi Gold Medal in the year 2006, and she is the best outgoing student during both her MS General Surgery as well as her MCH days also. So welcome, ma'am. We are looking forward to your words of excellence and make this gathering more colorful. Thank you, ma'am.
I request
Thank you for your
everybody
kind
to
introduction.
mute themselves.
Yes, madam.
I request all the delegates to mute themselves. Thank you.
Yeah. Thank you for the introduction. I'll share my slides first. Is it visible? Is my slide seen?
Visible or audible?
Visible, madam. You can make it full screen. Yes, madam. Now it is full screen. Yeah.
Yeah, here's an interesting topic.
I often and, today I will take you of topic.
Madam,
I'll take two, three, or four to
Madam, Madam, sorry to interrupt. Your voice is breaking, so I think your bandwidth is low. Yeah, you can switch off your video and.
Nandini, you can even open your phone hotspot. If you open the hotspot, it will give you extra. Switch off your video and open your hotspot on the phone so that your Wi-Fi will be strengthened.
Sir,
Sir, no
sorry,
audio, sir.
is it me or no other? Madam's voice is not
Voice
audible.
is not heard. Not
நர்மதா நீங்க ஃபோன் பண்ணி மேடம் சொல்லுங்களேன் கொஞ்சம். ஐ திங்க் ஷி இஸ் நாட் ஜஸ்ட் ஃபோன் பண்ணுங்க நீங்க மேடம்.
வீடியோ ஆஃப் பண்ணிட்டாங்கன்னா ஆடியோ வந்துரும் நர்மதா.
Now I'll just call her. I'll call her.
Yes, sir.
ஏன்னா உங்களுக்கு நம்ம சொல்றது கேக்குதான்னு தெரியல.
Your voice not audible. It's audible.
Okay. I'll check,
Now,
sir.
now it's audible, I think. Okay, you can proceed.
Am I audible?
Yeah,
very
now it
much,
is audible.
madam.
Yeah.
Now you are very much audible, madam.
Okay. Should I go through it again or it's okay?
Yeah. We missed the first two slides, madam. You can go
This
back.
one, is it?
Yeah, you can start from here. Yeah.
Okay, so we are going through a systematic order. The first thing is the bone, which we are looking at, and the second one is the solid viscera, which is normally present and create a soft tissue shadow in an X-ray. And then the ash odors, which we are looking at in any case of intestinal obstruction. The abnormal soft tissue shadows because of any cyst or a tumor, what we are looking at, and the foreign body go through. Sorry, I'm audible, sir.
Very much, madam. Very much audible, madam.
Okay. So in a plain X-ray abdomen, it's always mandate for us to ask, including the diaphragm and the pelvis. If you cut off the diaphragm, we are going to miss out on an air which is under the diaphragm. Air under the diaphragm is going to get missed out. And when the child is an adolescent, the plate is not big, so always they tend to miss out on the pelvis, which you should not do. So the abdomen X-ray should contain the diaphragm as well as the pelvis. In any taken point of view, whether it is supine or an erect. So I'll come to the detailing of supine and erect, which you are aware of. The other two major role players are the lateral decubitus and the cross-tubal laterus. We have diligently have its role in pediatric practice, particularly in neonates. So coming to the bony markers, we are interested in seeing what are the bony things which we are looking at in a X-ray abdomen. Last three ribs will be seen. The T12 to L5, that is the lumbar vertebrae in toto, L1 to 5 will be seen. The sacrum will be seen. And you know the flares of the iliac spines and the femoral heads would be seen. So the sacral promontory and the parts of your sacrum are very important because we are going to deal with anorectal malformation, spinal deformities, which are going to play an important role in the urinary continence and the stool continence. So we are interested in knowing if the sacrum is well formed or is it dysgenetic. So the one which is on the left side is normally the 5 P's of the sacrum, which is very well seen within the flares of your iliac bone. And whenever there is some kind of fusion, as you're seeing on the right side, when the vertebrae are not properly formed, the second and third are fused and the last one is fused, we call it a sacral dysgenesis. This is more
important when we are looking at any case of an anorectal malformation, because our prognostication for continence is going to be based on this. So if it is going to be a high ARM, you're going to look at a sacral dysgenesis and then prognosticate them for a proper modulation. This is, again, a picture is not clear because it's taken from a book. Sacral agenesis is very, very rare, but still it is possible in this kind of a cloacal malformation or a high ARM where the complete absence of the sacrum is present. And again, as I told you, the continence is at stake. So this two views, you must have come across this one thing where you have the sacral dysgenesis here with a dilated loop, that pediformous dilated. This is the newborn X-ray. So it must be an anorectal malformation. And the right X-ray, what the invertogram, the equivalent to the invertogram. As you all understand, when it was started to see the anal pit, the normal anal pit marker, and then you actually, initially it was like an upside down X-ray, which was actually a crude method of getting an invertogram. So it has become like a cross table lateral view. This is what I told you. This is an important view which is more useful in newborn X-rays when we are asking for this at the 24 hours of life. Whenever the part of it will give you a clue whether it is a low ARM or a high ARM. So this sacral dysgenesis along with the ARMs. So I'm trying to go through all the points which you pick up along with our surgical diagnosis. So another thing with the bony deformity. So you're able to see two X-rays here. On the left side, we have a chest X-ray. There is some kind of a lesion here sitting in the chest X-ray. You must have gone through plenty of X-rays what Dr. Gavelu has taught you in the last 2 weeks. And then this is kind of a hemivertebrae, whatever you're seeing in the chest region with a cyst. So if you come across something like that, what should be running in your mind? That is one on the left. On the right side, if you at the lumbar region, and this child is around 3-4-year-old, presenting with some abdominal symptoms. So when these two things are blatant at your eyes, this will invite a diagnosis of duplication cyst. So segmentation errors in the bone, whatever you call it, it's a butterfly bone or as hemivertebrae, or there is some spinal dysraphism. All of you will definitely ask for an MRI and look at the spinal cord and its anomalies, but nobody will see in front whatever is in the chest, whatever is in the abdomen. So abdomen side, whenever there is some solid lesion seen along with a segmentation error, or if it is a chest, instead of bronchogenic cyst and duplication cyst, if I see a shadow of this sort with the segmentation error, it is invariably a duplication cyst, not a bronchogenic cyst. Same comes here for the abdominal X-ray also. So now we have gone through the bone, whatever is important for a surgical point of view. Then when we are going for the soft tissue shadow, this is the anterior abdominal wall. So whenever you are, when you're looking at the soft tissue shadows, you first looked at the bony markings. Then you're going for the anterior abdominal wall. So whenever I just want to the abdominal wall, I'm looking at, always it is convex at the waist. It is like an hourglass. At the umbilical wasting, you have a hourglass-like pattern, and black line running the anterior abdominal wall. So that is a properitoneal line. This is a fat line which we can see in a normal abdominal X-ray. So the soft tissue shadow from the internal organs and the anterior abdominal wall will be delineated with in any normal abdominal X-ray. So this can get stretched out in any. If there is any anterior abdominal wall cellulitis, that is getting stretched out only on the unilateral side. If it is a generalized peritonitis on either side, this properitoneal fat line will disappear. So this is one of the examples where a 1-year-old has come with a full abdominal wall, an obese child. If you can see the X-ray, there are centralized bowel loops. That means there is ascites for the loops standing out, and there is full edema throughout. That means it is a nephrotic syndrome with a thickening of the anterior abdominal wall and some other findings internally as well. So this is another child with some abdominal wall injury. So you looks here on one side is So this is a traumatic wall injury having unilateral. So whenever it is systemic or abdomen, whether it is internal or external, the anterior abdominal wall also contributes to the soft tissue shadow, what you have to look for. So I'm coming to the solid viscera, which you have to look in any of your X-rays. So all of us know we have only 4 solid viscera. That is the liver, on both sides, the kidneys. The rest of the thing is the bowel wall shadows. So the other one, which the right hypochondrium is going to have liver shadow in shape. Spleen, as far as spleen is concerned, it is not going to give you any particular shape. It is only a soft tissue shadow which is going to be seen in the left hypochondrium. Most of the time, it just goes under the rib cage and it is not properly visible. And then coming to the psoas shadow, if you can see this kind of a flare on it. See, on the lumbar vertebra segment from L1 to 5, we have 2 ray of shadow on either side. That is the psoas muscle. So with this psoas muscle will be irritated whenever there is a retroperitoneal inflammation, retroperitoneal appendicitis creating inflammation, the child walking with the stooped posture. So all these things are retroperitoneal psoas irritation. The sedge can be seen. So the one
Madam, excuse me, madam. Your voice is not audible, madam.
சார் தங்கவேல் சார் மேடத்துக்கு நம்ம தொடர்ந்து தெரியல நினைக்கிறேன் சார். நீங்க ஃபோன் பண்ணி சொல்லுங்க சார் மேடத்துக்கு ப்ளீஸ்.
Madam, your voice is not audible.
I'll call her now. Your voice not audible. Maybe video off and try பண்ணி பாருங்க.
Hello.
Now you're audible, madam.
எந்த ஸ்லைட்ல கட் ஆச்சு சார்?
இல்ல previous slide madam. Previous slide.
இதுக்கு முன்னாடி ஸ்லைடா?
ஆமா madam.
அந்த psoas inflammationோட கட் ஆயிடுச்சு மேடம்.
Oh my goodness. I'm so sorry.
No problem, madam. You go ahead.
So this is the psoas shadow, and that's the liver and the spleen. So when we are coming to the kidneys, this L1 to 5 is the lumbar vertebrae which you are seeing in the abdominal X-rays. L1 to 3 is the position where you're going to look at the kidneys. So this soft tissue shadow, what you're seeing is from a plain X-ray only. So you have a psoas shadow, you have both the kidneys seen. This is called a nephrogram. This will be visible in a properly taken regular X-ray abdomen. So this is a contrast study where you can see the anatomy getting confirmed with the contrast draining through the ureters. Ureters will be seen alongside of the vertebral process. So coming to the bowel shadow, so here all of you tend to ask for an abdomen erect X-ray. This is a general surgery teaching where you see air fluid levels. In 2-3 levels are seen, then we are in for a laparotomy. So we cannot do a midline laparotomy like a general surgeon from the Ziffy sternum to the pubic symphysis. So we have to catch the problem by neck. So we need to understand what is the exact site of block. So that there comes this supine view. So the supine view, how different is it? So see, whenever this is the same child with the supine X-ray, this is erect X-ray. See, here we are getting so multiple air fluid levels, which is going to be present in any loop. You have the solid material of your food particles, you have the air, you have the liquid secretions inside, and everybody will be showing air fluid levels. So that is not the criteria for you to understand the problem here. So you have to understand there should be a post-obstructive dilatation. So whenever there is a ileal loop is blocked, then the proximal ileal loop or the jejunal loop has to be dilated. So we need to understand the pathology with the X-ray. So it is mandate to ask for a supine X-ray in pediatric practice. So any pediatrician or a pediatric surgeon asking for an X-ray abdomen in view of bowel pathology is supposed to ask only for a supine X-ray. I'll tell you why. So we have only there are four regions of the bowel which is going to create an air shadow. One is the stomach, second is the small bowel, and the large bowel. The small bowel, you have the proximal jejunum, you have a distal ileum. So you're going to segment it into 4 only. So these are the 4 loops. So whenever you must have come across this pile of coin appearance or a stacked or a racked appearance in an intestine. So plenty of you would have seen this kind of a CT picture with this kind of rugosity seen. So this is actually produced by the plaque circularis of the jejunal loops. So whenever you have a loop which is getting dilated beyond 2-3 centimeter and you have this kind of a pile of coin appearance with an air shadow of this sort, that means your jejunal loops are all dilated. So that kind of a looping is not seen in your ileal loops. So in ileal loops, it is characterless like this. It is only a blind characterless loops which are seen in the distal abdomen. So we are looking at a proximal abdomen distension with the jejunal loops which are going to create a pile of coin appearance, which are going to have characterless loops, which are these are ileal loops which are seen in this. So coming, so we are now differentiated between the distal ileal loops and the proximal jejunal loops. Now a stomach rugosity, you're supposed to understand it is an oblique structure with a greater curvature showing an oblique rugosity of this sort. And hostile pattern, all of you will be easily finding out that. And a hostile pattern, it is not always transverse, it will always hug the greater curvature and go. There will be a slight dip like this, like a U shape when you have a transverse colon image getting in an X-ray abdomen. So this is a good X-ray which shows the rugosity of the stomach in a plain X-ray, as well as the entire large bowel seen as you have in the anatomy, including the rectal gas shadow. So these filling defects of a solid and air particles or a punctate marks like particles are seen in a fecal loading in a colon. So this is to collate all the points what we have seen. You see this, the bone looks normal, sacrum looks normal, the abdominal wall looks normal, the properitoneal fat line is okay. And now you have the stomach rugosity seen. This is the colonic shadow which is hugging and coming down until the rectum, and the few loops which are seen in the center is not dilated. Few pile of coin appearance seen, that may be a single jejunal loop. So this actually becomes evident when you have a distended abdomen. So in a distended abdomen, the distal loops which is characterless are ileal loops. The ones which are like a pile of coin is a jejunal loop. So in pertaining to this, we are supposed to know this portal vein gas and pneumatosis intestinalis, which Dr. Rahul will cover. And pneumoperitoneum, as you all understand, this is a football sign appearance, or the one which will be highlighted by the liver and the anterior abdominal wall. So you have soft tissue shadow on either side, and this is the pneumoperitoneum. So I want to sensitize you for something more. So that unless it is evident like a football sign, we have some subtle markers at the early pickup for a pneumoperitoneum. So are you able to make out any kind of an abnormality here? It's still not fully like a pneumoperitoneum, but still you can see something like a bat wing standing just below the diaphragm. This is obviously a newborn X-ray. It is going to be in a lying posture. You're not going to get any X-ray standing posture to get air under the diaphragm. So this is kind of this is called a cupola sign. That is under either of the crux of the diaphragm. If you have a air pocket seen, an early pickup of a pneumoperitoneum, you can have this cupola sign. So again, you have a newborn, which you cannot, we are not able to make out whether the child has got pneumoperitoneum. Subtle abdomen distension is there. This lateral decubitus view will come into play. So you can just turn the child on to one side, that is left lateral position, and then the air will ascend up, and between the anterior abdominal wall the lateral parietus and the liver, you have this crescent of air, which will show you the pneumoperitoneum. Again, this cross-table lateral view will come into play in this. So this lying posture of the newborn baby, I'm not able to even rotate that. I have plenty of tubes running around. So whatever the cross-table lateral view we are asking for in nanorectal again comes into play. You actually place a plate of X-ray plate on one side and shine the beam from the other side. The ascended air of the pneumoperitoneum just sticks itself like a sliver of air under the anterior abdominal wall. So this cross-table lateral view, apart from the anorectal malformation, we can get it in the pneumoperitoneum as well. Now coming to the fourth part of it will be the abnormal soft tissue shadows. So we had a newborn which is having a suprapubic swelling. So this child has got a soft tissue shadow seen in the X-ray. So it's not arising from the bowel, it is over the a bowel shadow and it is a soft tissue shadow. So you have to find if it is a distended bladder, the child has voided urine or not. If it is a female child, you have to look at whether it is a hydrocolpos. So you have one soft tissue shadow jutting out from the pelvic region upwards until the umbilicus. Another soft tissue shadow, which is on the left side of the abdomen, it is pushing the gas shadow on one side. And here I'm not able to see the nephrogram beyond this. That means this must be a Wilms tumor or some tumor arising at that area. And this is a centralized soft tissue. And here, if you can see, the sour shadow is seen. So peritoneum is not irritated. The bowels are all displaced outside. This was a mesenteric cyst, which is playing all the bowels on all sides of the cystic lesion. So any soft tissue shadow with the site of origin, with the presence of your bowel and the normal soft tissue shadows, you should be able to come to some conclusion, but still it has to be confirmed by a higher imaging. X-ray alone is not important. Here we can look for, if it is a tumor, you can look for some calcification if it is a teratoma. Otherwise, it is a tumor. You have to have a higher imaging to confirm the site of origin. Now, apart from the other abnormal, we have two abnormal soft tissue shadows on the left one, which is like intense soft tissue shadow. The same here on the right side with the newborn, intense soft tissue shadow. That means it is shadow on shadow. A soft tissue is added on to the soft tissue. So if you have a bigger swelling like this in a newborn, so it must be an omphalocele. So ask for a lateral X-ray and you look at the bowels outside, then it is an exomphalos. So here, if you look at it, it is at the umbilicus. If you notice that is L4, L5 region, and you have a proximal dilated ileal loop, that means it is a obstructed umbilical hernia with the soft tissue shadow seen at the center. So often we get a call from the newborns to have a referral for a newborn hernia. So both of them are newborns. This is a relatively near-term one with a swelling here. They've called us as hernia. The right side one also is a preterm child, called us for a hernia on either side. But there is subtle difference. So here visibly the loops are all seen. And X-ray confirms that the loop, it is a scrotal hernia. That is the abdominal loops are all into the scrotum and then. But here, when you look at this preterm hernia, preterm, all the thin anterior abdominal wall, so the loops will be seen papery thin like this. But still the abdomen looks distended. Something wrong with the preterm. Then if you look at it, it is a pneumoperitoneum. And the air has tracked through the preterm hernia into the scrotum. This is a pneumoscrotum. So this is how we have to both correlate clinical scenario with the radiological picture as well. So not every single thing is the same. So last part of the foreign bodies in ICU, as you all understand, this must have been explained to you that the NG tube, ET tube, central line, ECG lines, the UAC and UVC, you need to understand the course. If there is a U loop here at the umbilicus and goes straight, it is a arterial line. And you have a line which is from the umbilicus towards the liver and turns to the left side of the portal vein, then it becomes a UVC. So with the X-ray itself, you should be able to pick up if it is a UVC or an UAC. So here is another one which was recently operated by us and had a liver transplant. So here, these are the foreign bodies which you are looking at. So you have to go from above downwards or below upwards. Here you have the phallus and one tube coming out. So this must be the urinary catheter. And there is one shadow which is in the bladder, has got a connection to the kidney level. One is at the lower level, one is at the upper level. Both are double J stents which are standing here. And this is the abdominal drain which we have placed after a liver transplant. And these are all metal clips for a liver transplant. You have the right IJ line in situ. So this is how you have to make out all the foreign bodies inside the abdomen. Can anybody guess what is this soft tissue shadow in a CP child, 2-year-old child coming for a regular follow-up? This is not a foreign body.
Pig. Gastrostomy.
This is a gastrostomy button. So gastrostomy button is something like your Foley balloon. You have a Foley balloon placed inside the stomach. You have a radiolucent line. You have a top portion. This top portion with the radiolucent line is what we are seeing as a gastrostomy button. So unless you are aware of a gastrostomy button, this will look like a foreign body to you. So after coming out from the soft tissue shadows, we are looking at calcifications. So as I told you, when we are looking at a tumor shadow, we are looking at teratoma with calcification. A newborn which is present at the day 1 of life with this kind of a calcification. Then we are looking into a diagnosis of a meconium peritonitis, where it has spilled the meconium, it has caused a chemical peritonitis and calcification in utero, and it is a meconium peritonitis. And the right side shadow is again, as I told you, we were suspecting in terms of a teratoma, but it had a spine-like lesion and the tumor was similar to an aborted fetus. So it is something called a fetus in fetu. So renal stone is another topic which Dr. Rahul will cover you. And a word about the coin and button differentiation. So any metal is going to look round in your X-ray, whether it is in the chest, neck, or in the abdomen. If you have a plain round like this, it is going to be considered as a inert coin. So in a battery, you have to look at this halo sign or a step sign. You will have a double rim sign. So always the button battery will have this one. So whenever you are looking at any rounded shadow, please do understand button battery is dangerous. If it is going to be lodged in the esophagus or trachea, it is going to cause a necrosis, and the mediastinitis is going to blow out of proportion. So coming to the common one is a lead pencil. So all of us had this doubt, and we even kept a lead pencil in an X-ray plate, and we have checked the lead in the black color lead will always be as of the soft tissue shadow. This is a blood pencil swollen and it is inside the stomach. And this, when it is having the wood, which is dark in color, only you will have the differentiation as a railroad sign. So this is the pencil at the neck of the child. This is on the stomach of the child. So if it is going to be a broken lead alone, in some hand or anything, it should have a puncture wound. It should be differentiated only on a guesswork, unless you have the wood around to differentiate you from the lead. So this is a magnet injection. I think Rahul will cover this. Multiple magnets will create an intestinal obstruction when it is pulling both the loops. When it is traversing through the loops, it will one-on-one will pull, and the ischemic necrosis between the loops is going to happen with an obstruction. So is gas visible, the glass visible as a foreign body in an abdomen X-ray? That is also a doubt. Glass is visible. Glass with some metal oxide is always visible like this, whatever be the piece and wherever it is visible. The radiolucent ones are the ones like wood, toys, plastics, and silicone beads. Silicone beads, you must have seen in that, which we keep it with the water absorbing silicone beads for the fish tank or anything like that. So this is another interesting X-ray of our own. The left side, you can see a soft tissue shadow. This is an abnormal soft tissue shadow, which is sitting just above the transverse colon. The transverse colon is pushed by the place where the greater curvature or the stomach shadow has to be there. So either it is a splenomegaly or some stomach lesion which is pushing the transverse colon down. Rest of the things look normal. Here you can see a faint gastric shadow. Along with that, there is a filling defect. So when we have two different X-rays, this turned out to be a duplication cyst on the left side, and this side was a trichobezoar, which is a filling lesion. Phytobezoar, trichobezoar, you must have come across with the children with who are needing psychiatric treatment. I think with this is the last slide for the foreign body. So we have two different X-rays here. The left one is again a normal X-ray, not a distended one, but the colonic shadow is entirely filled with something like a fecal material until the end. But on the right side, if you can see, the entire colon is filled with something like a particulate matter. This was a case of a silicone bead which was injected, and that will keep on absorbing and it will swell up and then it will cause intestinal obstruction like this. So the left one is a feculoma and the right one are the silicone beads. Silicone beads are, mind you, silicone beads are oxidized polymers. They are radiolucent. And the glass which has got a silica and the metal products will be radio opaque. So now we go on to the diaphragmatic problems. So the CDH is one who are all involved in an ICU and the newborn resuscitation would have been aware of this posterolateral defect in the diaphragm, which will allow the intestines to go into the chest, creating a pulmonary hypoplasia, pulmonary hypertension, which is going to be a nightmare for us for the initial ventilation and management. And then we take up for surgery, and this is a cushioning pneumothorax post our CDH repair. So this is the prime defect which all of us know. Next comes your second defect in the chest. So here you see a bowel shadow which is sitting on the left side, but still there is one white line which is hugging on the diaphragm contour. So this is the eventration diaphragm on the left side. So we have come across many of you taking this as a very light diagnosis. It is not so. It can lead into a very serious condition called a gastric volvulus. So whenever there is a somersaulting of this kind, whether it is organoaxial or a mesentericoaxial or combined volvulus, the stomach will toss itself. The child will be presenting with pain, retching. The child will not be able to vomit also. It will be an extensive nausea and retching. The NGT wouldn't enter this at all because the OG junction is going to be twisted. And if you don't act in time, this is going to go for a necrosis. And that will be a disaster like your midgut volvulus. So this eventration on the left side should be taken into consideration whenever you get at an X-ray for a Weezer or a normal check X-ray. You see a left-sided eventration, please do precipitate them to undergo a surgical repair so that you don't run into a surgical emergency like a gastric volvulus. Right side, it's obviously going to be a liver. If it is presenting in the newborn period or with some respiratory compromise, obviously surgery will come into play for an eventration diaphragm. Now, the third condition we have the lung fields are looking okay here, and you have the heart shadow, and there is one air pocket seen at the heart side. So here we will, it will help us to take a lateral X-ray. The lateral X-rays would have been explained to you in the previous classes. So here it is closer to the spine. It is on the posterior side. So we are looking at a diagnosis called hiatus hernia. So you have a esophageal hiatus, which can slide and pull up your the bowel gas shadow or the stomach shadow. And we have we recently had this rare type 4 paraesophageal hernia where the stomach and the large bowel was inside as a content of that. And we've come to the last part of the diaphragm defects. This is another one, which is a large defect. Again, it is showing a gas shadow over the heart. And we have the lung fields, which are very clear. As you can see on the right side, the transverse colon, which is with the horstrations, it's entering here. So now we are looking at a diagnosis called Morgagni. Why are we calling as a Morgagni? Because in a lateral X-ray, we do see this climbing in the anterior portion. We saw the hiatus hernia, which was climbing on the posterior side. This was climbing in the anterior side. So this is how a defect will look like with the contents going inside. We pull out that, and this is the huge defect which we repair, and they get back to normalcy without any bowel symptoms. So this is these are the diaphragmatic defects which we come across, mostly the Boctel-like hernia, which we told as the eventration diaphragm with a gastric volvulus has to be borne in mind. And this hiatal hernia is alongside of your esophagus, which is a natural hiatus, can allow as a bigger defect or the sliding ones. And the Morgagni hernia, which is more on the anterior side. Thank you for your attention.
Thanks, madam, for the wonderful presentation, exhaustive presentation. Although the X-rays were black and white, the message which was delivered was very colorful. And
I've stopped sharing the screen.
Yeah. Yes, madam. So we have come to the first half of our program today. The second half is going to be taken by a good friend, Dr. Rahul. As we all know, Rahul is a live wire in Chennai here. He did his undergraduate. He's a Coimbatore boy. He did his undergraduation in PhD Coimbatore. did his master's and super specialty in Coimbatore Medical College as well. He worked as for a short stint in ICH. He was the best outgoing student in the year 2015. He is a recipient of Professor K7 Pediatric Urology Award in the year 2017. And is also the recipient of Professor Dorairajan Minimally Invasive Surgery Medal in 2018. And he has been the gold medalist awarded by Tamil Nadu Dr. MGI Medical University. And is the only Indian for receiving the BAPS Traveling Fellowship Award in UK in 2021. And has been a contributor and a co-author in the IAP textbook of pediatric surgery. And is the first person in India to operate in giant thymolipoma via thoracoscopy procedure. And he has published two publications also in the same. So welcome, Dr. Rahul. We are looking for your presentation. The floor is yours.
Thank you, sir, for your warm introduction. And it's really difficult to talk after Nandini ma'am, after the extensive presentation. Sir, can you see my screen, sir?
Yes,
Yes, Rahul. Yeah.
Am I audible, sir?
Very much, Rahul.
Sure, sir. So,
but you are not seen.
seniors,
You are not seen.
Sir, my laptop is not showing face. I'm through my mobile. I've switched on my video, sir.
Okay, Rahul, your message is very clear. You can switch off and you can do your presentation.
Sure, sir. So, respected seniors and colleagues and my dear friends, and to thank IAP for giving me an opportunity to present in this forum. Today, I'll just try to bring in as many case scenarios as possible so that whatever I had gone through over these years will be admissible along with your X-ray so that you will have a broad perspective of what goes on in a surgeon's mind whenever you look at an X-ray. As we all know, as this picture suggests, everything may look alarming and difficult, more so when we look at the initial path, but this is just something known as an atavistic tale. In fact, this child was worshipped as Lord Hanuman in Lucknow for a long period of time, but the treatment was very simple. It was just an atavistic tail excision. Similarly, all these X-rays, though they look alarming, it is very straightforward when we have a clinical perspective to it. So all the X-rays which are going to see today is only an extension of a clinical perspective, and we'll all have an added point to it so that it can aid in a diagnosis or more so to add to further other investigations. So what are the common scenarios we take an abdominal X-ray? Most likely always, yes, a foreign body. The child comes to you with a bilious or non-bilious vomiting. For a lot of neonatal surgical conditions, because that is going to be a gold standard for diagnosis and treatment. Abdominal pain, very rarely, and there are certain pickups in abdominal pain with an abdominal X-ray. Mass abdomen, again, we after the advent of ultrasound and CT, X-ray, though obsolete, it has certain clinical signs to add to it. Constipation of late, yes, to look for a loaded colon, and certain other conditions. So madam has covered most of the foreign bodies. I'll just put up certain cases which was interesting over a period of time. This child was actually a doctor's child who had a history of button battery injection. The child had a button battery injection probably around 8:30 at night. And then the child was admitted in a hospital, and then the child was posted for endoscopy the next day morning. On endoscopy, they were not able to find the foreign body, and there was a suspicion whether we need to go in for a laparoscopy or laparotomy, which was highly obsolete. Subsequently, they took an X-ray. This X-ray showed the button battery to be lower down. So the teaching is, whenever we have a foreign body in the stomach, we are going to attempt a removal. Always take an X-ray just prior to endoscopy because it is a migratory foreign body. Like in a ureteric calculus, foreign bodies are also migratory. So an unnecessary procedure may be avoided. So always take an X-ray prior to shifting the child to the endoscopy at whatever time it is. And then coin, yes, coin mostly they tend to come out. As we all know, the narrowest part of the GIT is cricopharynx. So whenever a foreign body crosses the cricopharynx, there are high chances it may pass through any other orifice, be it esophagus, be it the stomach, esophagus, ileocolic junction, wherever it is. But very rarely when the size of the foreign body, for example, a coin or button battery is more than 2 centimeters, or when the child is less than 5 years of age, there are high chances it may get stuck in the pyloric junction. So what do we have as the norm for foreign bodies? What do we need to be afraid? Yes, button battery in the esophagus, irrespective of the position in the esophagus, needs urgent removal. Button battery in the stomach, we wait for 24 hours. After 24 hours, the button battery is still in the stomach. We do an endoscopic removal. If at all it has crossed the stomach, we wait for spontaneous expulsion. That is number one. Whereas if at all we have a symptomatic button battery, we go in and remove it. We have a waiting period of 24 hours for the button battery in the stomach. Do we keep the child NPO or feed the child? Obviously, we'll have to feed the child because we are giving him a chance for it to go down into the GIT. Whereas again, coin, we always wait. We wait for at least 24 to 48 hours. After 48 hours, we repeat the X-ray. If at all, after 1 week, there is non-propulsion of the coin, then we go ahead for endoscopic removal. Otherwise, if the child is asymptomatic, there is no role for coin removal within the 24 hours, or even for that matter, button battery within the 24 hours of ingestion, unless the button battery is more than 2 centimeters or the child age of the child is less than 5 years of age. At the same time, we have lots of other foreign bodies the child ingests. And if at all we look at a sharp foreign body, there are a lot of calls coming to us, sir, sharp foreign body, sir, small bowel, sir, please, sir, we should all know any sharp foreign body for that matter has a basic physics component to it. If at all we look at this foreign body, the sharp point will not be the leading point. The basic physics says whatever has the larger surface area will be the leading point. So the head of the nail will be the leading point always. Number it will not go sharp up to small bowel, large bowel. It's not what it happens actually. It is only the larger surface area, the head, which crosses through. So once it crosses the cricopharynx, esophagus, stomach, it will spontaneously come down without causing any trauma, because one, the leading point is the head. Number two, it will be covered with adequate amount of time. It will be in the center of the lumen. There are no chances that it will cause perforation. The same madam has already covered about magnets. Single magnet ingestion, we can wait. Otherwise, multiple magnet ingestion, as madam has suggested, one magnet can go through one intestinal wall, other magnet to other intestinal wall, both can stick together, causes intestinal necrosis, and the child can go on for small bowel obstruction like in the second X-ray. These are all X-rays of multiple magnet ingestions. Whereas this one is what madam has discussed. Sometimes there will be history of foreign body ingestion. Nothing will be visible on the X-ray, but the child will present with a small bowel obstruction. This is one of the cases where it came to me, small bowel obstruction, where the child had honey. The child had this polyabsorbent ball. It kept dipping in the honey, swallowing it, dipping in the honey, swallowing it. It swallowed somewhere around 20 to 25 polyabsorbent balls, and ultimately came with small bowel obstruction. And any idea what this foreign body is? You will see multiple foreign bodies throughout the X-ray. So this is post Diwali. Diwali is over. So they have a lot of leftover crackers. They keep it in a bottle. The child tries to firecracker it, and then it tries to turn backside and tries to run. You can see this is how it tries to run. The glass has burst, and there are multiple glass pieces through the various areas of your abdominal wall and chest wall completely together. So whatever you are seeing in this X-ray are multiple glass pieces through various parts of the body wall. So this is just to emphasize that children can come with varying presentations at varying points of time, and all of this is possible. At the same time, this child was presented to me with suspected appendicular perforation. There was generalized guarding and rigidity throughout the entire abdomen. And the child had was diagnosed to have a ADHD with history of multiple foreign body ingestions. So that prompted me to take an X-ray. On X-ray, if you see, there are multiple foreign bodies, one here, and one here, and one here. So then I took a CT. In the CT, I was able to see a foreign body was jetting out of the duodenum and going and hitting on the liver. So went inside through laparoscopy. On laparoscopy, this was the finding. It was complete peritonitis. And once a thorough wash was given, you will see one black foreign body jetting out. This is nothing but a hairpin. The black color hairpin the child has ingested, and after ingestion that has gone to the duodenum, and the duodenum it has perforated because of pressure necrosis, hitting on the liver, and I was able to take it out laparoscopically and close the duodenal perforation. Henceforth, as of now, this is the foreign body which I had taken out. Henceforth, we know for foreign bodies, the most worrisome one is obviously, yes, the button battery. Esophagus, we removed immediately. Stomach, wait for 24 hours. Double magnet, yes, always to be cautious. Third one, polyabsorbent jelly balls, multiple balls, small bowel obstruction. At the same time, length of the foreign body is also important. In a child less than 1 year of age, if the length of the foreign body is more than 3 centimeters, or if the child is more than 1 year of age, if the length of the foreign body is more than 6 centimeters, then it will cross the cricopharynx, esophagus, stomach. It will go to the C loop of duodenum. It will be held at the C loop of duodenum, and it will be staying there for a long time, cause pressure necrosis, and ultimately it will cause perforation. The varying foreign bodies I've seen is one with a hairpin. Second is the belt. You will see in the male belt, you'll have a center hook-like thing. The child will take it out and swallow it. That hook can alone then again cause pressure necrosis. If at all, what do we do for these kids? These kids alone, even if it has crossed the stomach, we'll have to take concurrent X-rays to prove it has crossed the C loop of duodenum. Because 2 cases, Malati madam had done an endoscopic removal, whereas this case came to us late with a perforation peritonitis. So we had to take it out laparoscopically. Hence, length of the foreign body is also important. Less than 1 year, more than 3 centimeters, or more than 1 year, more than 6 centimeters. Take repeated X-rays so that it crosses the C loop of duodenum. Otherwise, any other foreign body, be it any sharp, coin, or whatever it is, there is no role for therapeutic X-rays. Sometimes children come to us with 10 X-rays, 12 X-rays because we know the small bowel length is around 220 to 250 centimeters. We'll have to wait for at least 2 to 3 weeks for it to spontaneously expel. Whereas this child, like madam showed, had multiple episodes of hair ingestion along with ingestion of multiple means the multiple threads and everything. And ultimately, this was in fact a doctor's child who came to us with recurrent interceptions. And ultimately, X-ray showed a soft tissue side on the stomach. And ultimately, we were able to see a huge gastrobazar with tendency to go into the small bowel. And ultimately, because of the small bowel component, the child had intermittent colicky pain and interceptions. Finally, we had to take it out, give psychological counseling. The child is now doing well. And this is with regards to foreign body. Now, coming to hernia, we usually always prefer a clinical examination and an ultrasound with the hernia. The rare cases we take X-rays for hernias, like what madam has showed, a newborn with a huge hernia with in the scrotum, a huge scrotal hernia. The X-ray proves that everything is small bowel loop. Whereas any child who has a history of hernia, we operate on diagnosis. Otherwise, these children can come to us with bilious vomiting, a tender abdomen, and a hernial orifice is also tender. X-ray taken shows a clear small bowel obstruction. Intraoperatively, we'll be able to see a big knuckle of bowel sitting down in the inguinal canal and obviously causing small bowel obstruction. So any hernia, we operate on diagnosis. The only time we wait is for preterm hernias. In preterm hernias, we wait for preterm prematurity because prematurity has high chances of postoperative apnea. So wait for preterm prematurity and then operate on these kids with an inguinal hernia. Otherwise, inguinal hernias are always operated on diagnosis. Now, coming to lesions of the umbilicus, I'll just put forward to you certain interesting cases and points with umbilical lesions. There's a child with umbilical hernia who was, as obviously mentioned conservatively. We asked them to wait for spontaneous dissolution until 3 years of age. Even until 3 years, some books say even until 5 years of age. Until 5 years, we wait for spontaneous resolution. But there are certain instances where the children may present to us with abdominal distension, a tender umbilical region, and an X-ray revealing a small bowel obstruction. Subsequently, it will be an irreducible umbilical hernia going in for obstruction. The problem is, one of my close friends who was there in Tirupur, he had a child with umbilical hernia, newborn period. He advised conservative management. Every time the mother will come for vaccination, he will advise conservative management only. By around 11 months of age, he had gone for a visit to abroad. And subsequently, the child had abdominal distension and an umbilical hernia which was incarcerated, went in for gangrene, finally had a resection anastomosis. They filed a case on the consultant saying that he has not explained to us properly. He was very clear, sir, every time I had come, I had told them it is always chance of obstruction are there. So I went to consumer courts, 2 lakhs was awarded to the patient. He went into the High Court and subsequently High Court he thought will be in his favor. High Court clearly said you'll have to pay 10 lakhs. The reason pointed out was in none of your prescriptions you had written danger signs explained to parents. So, though we put umbilical hernia as conservative approach, always document in your prescription or your case sheet that danger signs has been clearly explained. Otherwise, we'll be under exploitation. Next, these are children who have a diagnosis on the spot. So you'll have a child coming to with fecal discharge in the umbilicus. At the same time, if you look at the upper abdomen, it is all dilated and distended bowel loops. You take an X-ray, classical small bowel obstruction, you go inside, it is a patent vitellointestinal duct. No other diagnosis needed. It is obvious through clinical examination where X-ray proves there is a small bowel obstruction. You go inside, it is a patent vitellointestinal duct. You excise it, do an anastomosis, child will do well. The same time, this was an interesting kid who presented with umbilical discharge to multiple practitioners, and obviously every time an ultrasound was done. The ultrasound was obviously done to rule out the patent urachus. but there was no obvious patent urachus. In fact, for a patent urachus, we'll have a finding like this. The subumbilical region, if you put laparoscope, we'll have a finding like this. But this child didn't have a patent urachus, so was managed conservatively. Suddenly, the child presented to us with bilious vomiting. So whenever you have a persistent umbilical discharge, or in fact a lot of pus coming out with an abnormal lesion in the umbilicus, child presenting to you with small bowel obstruction, always think of a delayed presentation of either a patent vitreointestinal duct or a duplication cyst which is stuck in the umbilicus. So any abnormal lesion in the umbilicus prolonged for a period of time crossing the age group where we think it should resolve, always go in for a higher investigation. Otherwise, the child may land up in small bowel obstruction. This is how the child landed up to me with an acute small bowel obstruction stuck to the umbilicus, did a resection anastomosis of the duplication. The child did well. And then for neonates, obviously, yes, X-ray is going to be your investigation of choice. Now we have three conditions where we take an X-ray in a neonate. One, the child has not passed meconium. Number two, the child has a bilious vomiting. Number three, the child has a distended abdomen. So whenever the child has not passed meconium, our basic dictum is first to examine the anal orifice. So we look for an anorectal anomaly. So absent anus is the first one we need to see. This may be varying anomalies, a low, intermediate, or high anomaly, and it may be in male or female. And as Madam pointed out, this is what Madam was trying to tell. Earlier, we used to take an X-ray like this, which is an invertogram, which is highly barbaric. There were high chances of intraventricular hemorrhage, higher chance of aspiration. Hence, we modified the X-ray in such a way that we did an X-ray like this. A child placed in a cross-prone table lateral view. Cross-prone table lateral view X-ray. Why is this X-ray taken? This X-ray is obviously taken to assess the level of your anomaly. So this is based on a levator trani muscle. So whenever the gas shadow is above the level of levator trani, it is a high anomaly. When it is within the levator trani, it is an intermediate anomaly, or when it crosses the levator trani, it is a low anomaly. So this is how a cross-prone table lateral view X-ray will look like. This is the bowel gas shadow, and this is the line known as the PC line, which is the upper border of levator trani. And this is the eye line, which is the lower border of levator trani. And based on where the gas shadow is, we classify it as high, intermediate, or low. And this classification determines our management, whether it is going to be just a perineal procedure or a colostomy. Number one. Second thing is prognostication. Higher anomaly has higher chance of incontinence, whereas intermediate and low has lesser chances of incontinence. Hence, for a child not past meconium, when there is absence of anal opening in the perineum, we always take a cross-prone table lateral view, a special X-ray to assess the level of anomaly. At the same time, always remember, whenever we have a neonate with one anomaly, it happens at some point of your fetal period, in your antenatal period, that all organs are developing. So always screen for other anomalies. In the X-ray, what else can we see? As Madam pointed out, we always look for your sacral pieces of the bone. In this X-ray, if you see, the sacral pieces are absent. Hence, an AP view and a cross-prone table lateral view will clearly tell us when there is associated sacral anomalies in a child with an anorectal anomaly. Whereas some female children will have only one opening. The entire opening will form a single opening. Again, this is a condition known as cloaca. This is not anorectal anomaly because there only your anus is absent. Here, all the openings, your vaginal opening, your urethral opening, and your anal opening are at a single opening known as cloaca. At the same time, is there anything in an anorectal anomaly X-ray you can pick up? Yes. There are sometimes you'll have a huge gas shadow in your X-ray, in an AP X-ray. This clearly shows that it is a pouch colon, or the colon will be in the form of a pouch. This is a high anorectal anomaly. This is again, rather than taking a cross-prone table lateral view itself, if you take an AP view of the X-ray itself, you will be able to find out a pouch colon, which is a high anomaly. So newborn has not passed meconium. We looked at the anal orifice. Now anal orifice is normal. Now what do we do? So now what do? We take in a lubricated feeding tube. We put the feeding tube through the rectal opening. When we put the feeding tube through the rectal opening, we make sure it crosses around 2.5 to 3 centimeters. If it has crossed beyond 2.5 to 3 centimeters, the rectal atresia is ruled out. Now what do? Initially, this is the X-ray of a child not past meconium with a normal anal opening. So we give a wash. Once we give a wash, if there is a thick tenacious plug coming out, this is known as a meconium plug. And after this, we see if the child is passing meconium spontaneously. The child passes meconium spontaneously after meconium plug evacuation. It is meconium plug syndrome. So this is the X-ray of the child. You will see there is an absent rectal gas shadow. Child not past meconium beyond 24 to 48 hours, absent rectal shadow. We put in the feeding tube, we give a wash, passage of meconium plug. After that, the child passes meconium spontaneously. It is meconium plug syndrome. Whereas the child passes meconium first after the wash, but does not spontaneously decompress after that. We are thinking of Hirschsprung's. Once we think of Hirschsprung's disease with an X-ray revealing an absent rectal gas shadow, we take a contrast study. In contrast study, as we all know, we have a narrow aganglionic zone below and a hugely dilated ganglionic segment above. A classical Hirschsprung disease, the diagnosis is obviously proved. Intraoperatively, we see a huge dilated ganglionated segment and narrow distal aganglionated segment. This is again another picture to show you a huge dilated ganglionic segment and an aganglionic segment. So this is how we prove diagnosis of Hirschsprung. So the child is not past meconium. We take specific X-rays for anorectal anomaly 1, number 2 for Hirschsprung's and meconium plug. At the same time, we give a wash. There is no meconium coming at all. We have only mucus plug. The child has vomiting. That means the meconium has not been exposed to the small bowel. Then we take an X-ray. In X-ray, if we have an X-ray like this, you will have only a distended stomach only. There is no gas shadow below. Then it is only the stomach. We have a diagnosis of a pyloric atresia. In pyloric atresia, we look for epidermolysis bullosa, a syndrome known as Carmey's syndrome. But not past meconium, a distended abdomen, X-ray revealing a large gastric bubble, it is pyloric atresia. At the same time, the child has bilious vomiting and a distended upper abdomen, not past meconium. Then we have a diagnosis in mind. Always remember, any newborn with bilious vomiting with the double bubble, don't go in for duodenal atresia first, dear PGs. Always rule out malrotation. Newborn bilious vomiting, it is malrotation unless proved otherwise. You will have a dilated stomach, you will have a dilated duodenum. Whenever you have paucity of gas below, then it means the child has a malrotation along with a volvulus. Very, very important. Whereas if you have a dilated stomach and a duodenum with gas shadow below, it may be just malrotation. But paucity of gas means from the duodenum, the entire gas supply is cut off, which means the child has a volvulus along with malrotation. So what is going to be next investigation? Obviously, you'll do an ultrasound to rule out the axis, SMA and SMV axis. Usually vein should be to the right. If at all you have alteration of SMA, SMV axis, it again points more towards malrotation. But finally, what is going to be a gold standard in diagnosis? A contrast X-ray. In contrast X-ray, what do? You put in the contrast and look for the position of DJ flexure. If in upper GI contrast, if the DJ flexure is to the right of the spine or over the spine, you make a diagnosis of malrotation. So double bubble, bilious vomiting, malrotation should be first on the list. If malrotation is suspected with again an alteration of SMA-SMV axis, you do an upper GI contrast study, look for the position of DJ flexure to the right of the spine. You have confirmed malrotation, go in. Why is it important? You go in early, you will be able to save the bowel like this. You go in delayed, the entire bowel supplied by the superior mesenteric artery will go in for complete gangrene. This is again the picture to show you. This is the volvulus. You can see multiple turns here, 3 turns of volvulus here. And this is the classical malrotation of volvulus presenting early. If at all you go late, the entire thing will be pitch black gangrene. And you all know that intestinal transplant is very, very difficult in the newborn period. It will take a few months for the child to be ready for transplant. And intestinal transplant has the highest rejection rate because of high amount of lymphoids aggregate. Hence, has to be diagnosed early. Any bilious vomiting in newborn, malrotation should be a first diagnosis. If malrotation is ruled out, then you go ahead with the duodenal atresia or a triple bubble. You go ahead with jejunal atresia, or you have paucity of gas below with multiple proximal dilated loops, you go in for a jejunal or a jejuno-ileal atresia. This is the classical jejuno-ileal atresia, newborn presented with bilious vomiting, not past meconium, with bowel showing multiple proximal dilated small bowel loops. You go in for jejuno-ileal atresia. This is with regards to a healthy child who presents to you with bilious vomiting. Now we have a preterm child or a term child who has a necrotizing enterocolitis. What is the role of X-ray? So, if you look at the abdomen, it is grossly scleromatous. What should we look at the X-ray? There are only 2 points which are very, very important. Point number 1, as Madam pointed out, gross pneumoperitoneum. We know Nnec is an evolving disease. So, repeated X-rays is mandatory in a Nnec to know whether the child is progressing for pneumoperitoneum. Hence, repeated X-rays will clearly tell us this pneumoperitoneum is picked up early. At the same time, is this only pneumoperitoneum we have to see? No. There is something known as a fixed loop. So, you take an X-ray, you will see there is one loop here. You have taken the X-ray on repeated days. In all 3 days, you will see this loop is fixed here. That means beyond this, the gas is not progressing. So there is an area of ischemia or a sealed perforation at the point of probably a terminal ileum. Hence, in an NEC kit, look for pneumoperitoneum on X-ray, look for fixed loops on repeated X-rays, you go in. The same time, is there any clinical sign we can see? Yes, because of patent process vaginalis, these children, preterm children with pneumoperitoneum can have crepitus. You palpate the scrotum, you'll have crepitus because of air within the scrotum, and obviously these children on laparotomy will have a perforated segment. So you do a stoma come out, the child will do well. At the same time, on the other hand, there are certain children who are extremely preterm kid who have been given CPAP. So we know we obviously decompress the stomach while giving CPAP, but in spite of decompression, if the decompression is inadequate, the child can present with gross pneumoperitoneum. This is a preterm, extreme preterm child, CPAP given gross pneumoperitoneum, and we put in a flank drain. So we know with this child, the history is most likely pointing towards a gastric perforation. Huge pneumoperitoneum, CPAP child, yes, gastric perforation. Most of these gastric perforations are posterior gastric wall perforations which spontaneously regress. Whereas this child progressively started deteriorating. It had poor counts, abdomen was scleromatous, child was becoming sick. We took repeated X-rays. If you see the repeated X-rays, I was able to see persistently distended gastric shadow. And all 4 days, persistently distended gastric shadow, which clearly revealed there is a gastroparesis. And obviously, child was sick and hence had to go in. Once this flank drain didn't work, once we went in, there was a huge gastric perforation. In fact, there was a partial gastric necrosis. A perforation at one point of the stomach, the entire greater curvature went in for necrosis. I had to do a partial gastrectomy, and subsequently the child did well. Hence, the teaching is CPAP. When you have a gastric perforation, it is invariably conservative because it's going to be a small perforation. Whereas the child is deteriorating, persistent gastric shadow in the repeated X-rays with a deteriorating kid, always go in for laparotomy because you may be able to save the kid with just a laparotomy. The child will do well. Now, we have seen bilious vomiting. We have seen a distended abdomen. Is there any condition where the child can present to you with a combination of both? Remember, the only neonatal surgical condition which presents with abdominal distension at birth, it is meconium ileus unless proved otherwise. That is the only condition the child will have abdominal distension. You take an X-ray, you will see that this is something known as a soap bubble appearance. Soap bubble because the problem is not in the intestine, the problem is in the meconium because of the thick tenacious meconium. Whatever gas the child cries and swallows will be within the thick tenacious meconium plug, hence you'll have a classical soap bubble appearance or a Neuhausser's sign, mostly evident in the right hypochondrium. This is because the air percolates into the meconium. Whereas this is usually managed conservatively with a diagnostic or a therapeutic contrast where you'll see an unused colon. The contrast is put, this is the unused colon. Most of the time, the meconium gets washed out. Whereas the child has a gross distension at birth, the child is deteriorating over a period of time. You see there is a gasless abdomen totally, only fluid filled, you will see a meconium peritonitis. In these conditions, obviously the child may not have a gross improvement with just a contrast study. So abdominal distension at birth along with bilious vomiting and child not past meconium, always think of meconium ileus. A simple meconium ileus where you will have a Neuhausser's sign, a complicated meconium ileus or a meconium peritonitis where you can have a grossly gasless abdomen. Now coming to tender abdomen in an elderly pediatric patient. So tenderness in the abdomen may be in the right iliac fossa, which is the most common condition which we commonly come across. it is invariably appendicitis. Appendicitis, obviously, ultrasound and CT are going to be an investigative modality. If we had taken X-ray, you will see there will be paucity of bubble gas in the right iliac fossa. Rarely you will be able to pick up fecolids, huge fecolids you will be able to pick up. The same time, remember, we have got a lot of conditions where the children initially thought to be appendicitis because the ultrasound probe has mentioned only RIF probe tenderness. There is one history which we all feel is very, very important. Whenever we have abdominal pain followed by fever, it is surgical unless proved otherwise. Whereas the child has fever first, followed by abdominal pain, we have to rule out all medical causes. In fact, enteric fever, leptospirosis, dengue, DKA, all of them can present it with RIF tenderness. Hence, we'll have to rule out all possible medical causes. The child has first fever followed by abdominal pain. Whereas when we have diagnosed appendicitis, we have to go in early. Otherwise, the child can present to us with gross peritonitis. This child came to us 6 days later with complete pus within the entire abdominal cavity. In fact, there were around 1 liter of pus in the entire abdominal cavity, a sloughed out appendix. Hence, RIF tenderness, all investigation pointing towards appendix, go ahead with surgical opinion immediately. At the same time, it is only not an RIF tenderness. If at all you have a suprapubic pain or a suprapubic tenderness, if you take an X-ray in them, if at all you take an X-ray before an ultrasound, if you look at lesion in the pelvis, this is the calcified lesion in the pelvis. In fact, this was an ovarian dermoid. So always remember, any colicky pain in a female child, it is ovarian torsion unless proved otherwise. This may be a primary ovarian torsion or secondary to some pathology. X-ray may sometimes be revealing. So we know the ovaries are at the lateral end. It is on either of the adnexa. Why do we have a lesion at the midline? Because whenever the ovary torses, it will have a venous congestion. And this hugely congested ovary will fall on the midline because of its weight. It will not stay in the adnexa. It will fall on the midline. Hence, we'll have a suprapubic tenderness, and many a time we'll mistake it to be cystitis. At the same time, your lesion will be exactly in the midline because of a torsed ovary. And this is again a torsed ovarian dermoid. You can see all these dermoid components inside, which are calcified in the X-ray. We come upon it early. Then we do dermoid excision child as well. If it is going to be a simple ovarian torsion without any dermoid, you can see this is the pitch black dark ovary. We do a detorsion, the color improves dramatically. Hence, lower abdominal pain, female child, always think of ovarian torsion. At the same time, it will be a midline pain. You can look for midline calcifications in X-ray to rule out an ovarian teratoma. Whereas if you have a strangury pain, this is commonly we see the Belinitis erotica obliterans who come with a thin stream of urine. The tip will be whitish in color. The child presents with a thin stream of urine, and rarely they can present to us with an acute urinary retention. At the same time, I'll give you a scenario. This is a 4-year-old child who was otherwise well, no history of BXO, comes to with sudden onset urinary retention. We all know newborn with dribbling of urine, urinary retention, it is post-urethral valve. Whereas an otherwise well child coming to urinary retention, always look for a urethral calculus. You'll see this is the urethral calculus here. And very, very important, whenever you suspect a urethral calculus in an acute retention of urine, always take an X-ray such that the penis is laterally tilted. If you take just an AP view, you will have an end-on view. So you will not be able to see the calculus at all. So you will see the penis is tilted to one side. It is tilted to the right. That is when you will be able to see a calculus. So acute retention of urine, otherwise well child, when you have suspect a urethral calculus, always take an X-ray KUB and make sure you take the penis to the right. At the same time, this child presented to me with history of circumcision. Circumcision was done 1 month ago with strangury pain. Classical symptom will be, sir, irukki pudinjida sir urine poram. Vaithukile irukki pudichi urine poram will be the classical history. A classical strangury pain. Whenever we have a strangury pain, point number 1, we think of trigonitis. Any trigonal irritation can have strong strangury pain. At the same time, always rule out a vesical calculus. X-ray will reveal a huge vesical calculus, and any strangury pain, always rule out a vesical calculus, which will be a radio opaque shadow in the bladder. Children can have other stones? Yes, children can present to you with abdominal pain. You take a plain X-ray, you will be able to see huge stagon calculus. This is just a CT to prove a huge stagon calculus. And obviously with mini perk, we'll be able to do an endoscopic removal. Yes, stones are also possible in children, and X-rays are very, very easier investigations. Rather than subjecting to the child to CT first, all radio opaque calculuses can be picked up with just a plain X-ray. Now, coming to the next important topic. Last 2 or 3 topics, and I'm finishing this session. Now, the most important topic now is bilious vomiting. Newborn, we know any bilious vomiting in a newborn, we think of malrotation. So this was an 8-year-old child who presented with bilious vomiting. This bilious vomiting was not one episode. A child has bilious vomiting on and off for a period, for at least 3 to 4 months. One child has bilious vomiting. I take an X-ray. In this X-ray, can you see the alarm picture? You will see the stomach is here. The entire small bowel is to the right. So I've done an ultrasound. I've taken a CT. I've made a diagnosis. I go in with laparoscopy. Again, the same finding. This is the right side of the abdomen. The entire right side of the abdomen is filled with small bowel loop, whereas the large bowel loop is on the left side of the abdomen. And this is the intraoperative picture. Intraoperative picture, I was able to see large amount of lymph. And obviously, the diagnosis is malrotation. Yes, only 80% of malrotation presents with the first month of life. Another 10% of malrotation presents within the first year of life, whereas the last 10% of malrotation can present any time in life. Hence, whenever a child presents to you with bilious vomiting, again, the child is older, also think of malrotation even in an older kid with bilious vomiting. So these children usually present with intermittent bilious vomiting because they have an intermittent volvulus. There will be a volvulus, then it will be derotation. Volvulus, derotation. The evidence is by means of a lymphatic rupture. You will see the entire lymph is ruptured and it's within the abdominal cavity. So this intermittent abdominal pain with bilious vomiting, even in an elder child, think of malrotation. Whereas this is a child who, this was around our 8 years old child who presented with sudden onset bilious vomiting, only one episode. The child was admitted in a nursing home and subsequently the child developed rapid onset of abdominal distension. Child became delirious. They shifted to a higher center. ABG revealed severe metabolic acidosis. The child had a tender abdomen. So this is an otherwise well child. Only 2 days acute bilious vomiting and subsequently the child went in for metabolic acidosis. I've made a diagnosis with a CT, subsequently went in, this was the finding. This was a Meckel's band causing complete gangrene. This is a small bowel which has gone in for complete gangrene. The same time, there was another 2 years old child, otherwise well, sudden onset bilious vomiting. X-ray revealed a small bowel pattern, local volvulus, again a gangrenous small bowel loop. Hence, whenever we have a sudden onset bilious vomiting in a child, irrespective of age group, think of Meckel's band, number 1. Number 2, 6 months old child with intermittent colicky pain. We all know we have to think of intussusception. And intussusception, we all know there will be paucity of gas in the right iliac fossa, and you will have something like a pincer claw. This is X-ray, though not classical. It will be evident only in barium studies, which we are not doing it now. This is a pincer claw sign on X-ray. So 6 months child, intermittent colicky pain. We all know any colic is ischemia unless proved otherwise. Female child, lower abdomen colicky pain, ovarian torsion. 6 months old child, intermittent colicky pain, intussusception with impending ischemia. We do an ultrasound. If referred early, hydrostatic reduction. Referred late, we have to do an open reduction. But sometimes these children can present with bleeding PR and a bowel gangrene which needs to be resected if presented late. Whereas there are some children with intussusception, an ultrasound proven intussusception with gross small bowel obstruction. You will have an intraoperative finding like this. So you need not have an ileocolic in all instances of intussusception. This is a classical ileal intussusception. Multiple ileal segments getting intussuscepted. So whenever you have a small bowel intussusception, always look for lead points. These lead points may not be evident in all X-rays, may be evident in CT. And when you have polyps, always examine the oral cavity because the children may have an inherent Peutz-Jeghers syndrome. In fact, this child had Peutz-Jeghers, child's father had Peutz-Jeghers, for which laparotomy was done. Hence, 6 months old child, intermittent colicky pain, think of your intermittent ischemia, which is classically seen in intussusception, whereas this may vary from age groups between 3 months to 3 years. Whereas now we have a pattern. We know otherwise well child is going to present to you with bilious vomiting. You take an X-ray. X-ray reveals a small bowel pattern. You have ruled out malrotation. You have ruled out Meckel's band. You have ruled out the third possibility of an intussusception. What is the next possibility you should think of? You should think of a duplication cyst. This is a cecal duplication cyst. These are all otherwise well children with a small bowel obstruction. This duplication cyst is at the level of cecum here. The same time, you can have a duplication cyst at the ileum. If you note this, This is at the mesenteric border, the duplication cyst. Usually the Meckel's will be at the anti-mesenteric border. So this is a duplication cyst. Or you can have acute small bowel obstructions. CT again taken shows huge chirolymphatics. This again a variant of mesenteric cyst where the child can present to you with a small bowel obstruction. So to put it in gross, always remember acute small bowel obstruction. This is how you go about one by one. It is small bowel X-ray showing a small bowel pattern. If it is small rotation, Meckel's band, a duplication cyst, or interception in the order of priority. Very rarely, the appendix can compress the ileum, a condition rarely known as an appendicular tie syndrome. Whereas you have a child with a bilious vomiting, but a non-distended abdomen. You palpate the abdomen, abdomen is tender. Clinical examination is mandatory. You will be able to see a scar. Whenever you see a scar in an abdomen with X-ray revealing a small bowel pattern, always rule out adhesive obstruction. Any surgical scar is prone for adhesive obstruction. Clinical examination is mandatory. Combine it with an X-ray which shows a small bowel pattern, most likely a closed loop obstruction. This is a closed loop obstruction. You relieve the obstruction, child will be well. Is there any other scenario we need to look at the abdomen examination? Yes. This is something known as a seat belt sign. Similarly, this is another sign where the child was driving a bicycle at home. It hit on the wall. The bicycle handlebar turned and then hit on the abdomen. And subsequently, we take an X-ray on the child's arrival. The X-ray is absolutely fine. The child goes home, comes next day with gross abdominal distension. We take an X-ray, it is pneumoperitoneum. Remember, this is a sign known as a London sign or a patterned aberration, which means whenever you have an impression on the abdominal wall of the hitting organ, be it a bicycle, be it a seat belt, or whatever it is, when you have a patterned aberration, then the child has a high chances of hollow viscous injury. But the take-home point is the first X-ray will be normal. These children will be presenting to you only 24 to 48 hours later. Hence, whenever you have a patterned aberration, always admit the child. Look for delayed investigation. You will be able to pick up perforation later, 24 to 48 hours after. And this is classical patterned aberration, a sign known as a London sign. So the last two topics, whenever you have a distended abdomen, this is a child with a classical history child actually present with obesity to one of the practitioners, and with an Ayurvedic practitioner, child was given a lot of Ayurvedic drugs. The mother gives classical history, sir, moonjallam vattirchu sir, vair mattum vattave illa sir, அப்படியே இருக்கு அப்படின்னு சொல்லிட்டு. X-ray was taken. X-ray shows no bowel obstruction, but a huge mass here in the pelvic area. And obviously the child had a huge ovarian cyst. This ovarian cyst showed large amount of fluid, and subsequently the ovarian cyst was excised laparoscopically. And hence, an abnormal history with an abnormal presentation, X-ray, though not revealing, may tell us a particular clue in certain these interesting cases when a huge shadow may be evident on a plain X-ray, but anyway, the diagnosis is going to be confirmed by your ultrasound or a CT. And this is a child, again, a classical history presented with gross abdominal distension. The child says, sir, whenever I eat something, I have a gross abdominal distension. And subsequently, it is okay. But whenever I have an abdominal distension, I have a respiratory distress. So children may have problems at one system, whereas they can present to you with another system complication. So this child had abdominal distension, but at the same time respiratory distress. So X-ray taken revealed a gastric shadow here. As madam has shown about eventration and Morgagni hernia, there is an entity known as delayed diaphragmatic hernia, where the diaphragmatic hernia can present late. This is in fact a 12 years old child who has been having symptoms long period of time, failure to thrive, and X-ray showed a distended stomach in the chest. You do a contrast study, you can see the stomach classically within the chest, and you do a laparoscope, you see this is the diaphragmatic defect, the stomach is seen within the defect. You close the diaphragmatic defect and the child does well. Any other abnormal conditions where you can have abdominal distension? Yes, this is a palpable mass, hard palpable mass with abdominal distension. Remember, any hard palpable mass in a child, always think of Wilms tumor. You will see a soft tissue shadow on X-ray, though CT is going to be a diagnosis. Wilms doesn't usually cause calcifications. As madam told, teratoma can cause calcification. Same time, neuroblastoma, which can present with an abdominal mass, can present with coarse calcifications like this on plain X-ray. Though CT is going to be, or next investigative modalities. at the same time, rather than having a distension on one side of the abdomen. This is a newborn child who has an antenatal history of a cystic lesion in the abdomen, presents to me with gross distension of the abdomen. I palpate the abdomen, there is a cystic lesion. Now, there is only two important X-rays which we need to know. X-ray number 1, you see a hugely distended abdomen, but there is no gas at all, which means the cyst is overlying the bowel gas shadow. This is something known as an umbrella sign. The entire cyst is overlapping the gas shadow. This is again another baby with the same finding. You put in a laparoscope. This is the picture. This is something known as an omental cyst. You will see there is no bowel loop at all outside. It is all beneath the cyst. So a hugely distended abdomen cyst, which is like this, or a mesenteric cyst. Whereas you have a hugely distended abdomen, but you take an X-ray. In this X-ray, you will be able to see bowel loops. Can you see? You will see bowel loops here. These are all bowel loops over the mass, which signifies this is not an intraperitoneal mass. This is a retroperitoneal mass. This retroperitoneal mass invariably most likely will be a teratoma, more commonly in female children. So abdominal distension, gross abdominal distension in a child less than 1 year. If at all you have no bowel loops visible on X-ray, only the cyst is visible. It may be an omental cyst or a mesenteric cyst, but you have visible cysts here. Visible bowel loops here, but you see a grossly distended abdomen, then it is a teratoma. This was a special variant of teratoma, as madam pointed out, a fetus in fetu. You will see this is the head of the fetus, the spine of the fetus, the tail of the fetus. But this child, in addition, had a Wilms tumor. This was a fetus in fetu with Wilms tumor. The first case, in fact, reported as per literature worldwide, a fetus in fetu with Wilms tumor. But remember, whenever you have a retroperitoneal lesion, think of a teratoma, or in fetus in fetu, we can have all these bony components like spine, bone, and all can be visible. You can see all these bony lesions, which is a characteristic condition known as fetus in fetu. So now coming to the last two conditions, this child again, the same abdominal distension, same clinical feature, abdominal distension. But at the same time, as I told you in a previous X-ray, the child also had a respiratory distress and high-grade fever. So I was thinking of a delayed diaphragmatic hernia. No, we take an X-ray, X-ray reveal a large loop in the chest. So I go inside with a diagnosis of a small bowel obstruction, probably because of Morgagni. To my surprise, there was pus inside the chest. And once I evacuated a pus, I was able to deal with a gangrenous appendix inside. So this was a huge Morgagni hernia with, this is a huge Morgagni hernia here with an appendicular perforation inside the thorax. This was a giant Morgagni hernia with an intrathoracic appendicular perforation. Though the problem is in the diaphragm, the child presented with abdominal distension. So the problem was there, and child had peritonitis, but subsequently the diaphragm had to be dealt with in these children. The same time, this was an interesting X-ray. The last week, the child came to me, 4 weeks old child, non-bilious vomiting, and obviously this was a term male child. You think of pyloric stenosis, hypertrophic pyloric stenosis. The X-ray was classical of hypertrophic pyloric stenosis. Subsequently, you examine the child, there was cyanosis. So this X-ray, if we had missed, if we seen only the abdomen, think of pyloric stenosis, do an ultrasound, go in with surgery, we'd have missed this important clinical finding. You will see the heart. This is a classical box-shaped heart on X-ray. So when you can see, this is the classical figure of 8. A figure of 8, classical figure of 8 on X-ray. So whenever you look for a pathology in one side in an X-ray, always look for concomitant pathologies in the other part of the X-ray. Read the X-ray from the chest to the thorax, because you would have missed a figure of 8 classically in these children with hypertrophic pyloric stenosis. So the last condition today is with regards to constipation. We have been dealing with constipation back and forth in our OP. You take an X-ray. This child, in fact, referred to me as sigmoid malignancy. The child had only constipation. You take an X-ray, you will see a loaded colon. But in this loaded colon, you have a child rapidly treated for constipation over a period of months together. You have a loaded colon. But the most important clinical finding, which we usually tends to be missed, is the anorectal opening. So always do a perrectal examination in a child who has been treated for constipation for a long period of time, because anocutaneous fistula or an anorectal anomaly may be missed at birth. I've seen children at 3 years, 5 years, 8 years, 12 years. Classical, sir, murukku pulira mari motion poren, sir, will be the classical history, because in the newborn period, they could have missed it, saying that the meconium has been passed, because it's a very small opening. Through this small opening, child can pass meconium, but it will not pass stools. In fact, the opening should be like this. This was an anocutaneous fistula missed at birth, and subsequently the child was treated for constipation. Multiple X-rays taken, all had only a loaded colon. This is again a 12-year-old child who was missed anorectal anomaly at birth. For 12 years, he's been having only constipation, treated later. This is again a 5-year-old child. Again, anoplasty had to be done for all these children. At the same time, you have treated constipation, but the child has not improved. Is there any other investigation we have to do? Yes, we have to do a barium enema. In barium enema, obviously, we know for Hirschsprungs, we do a barium enema, but for older children, we do a barium enema for a condition known as internal sphincter achalasia. The earlier term was ultra short segment Hirschsprung disease, where a narrow zone of aganglionosis was there. Now the term has been changed to internal sphincter achalasia, where what is more important? Your 24-hour delayed phlegm is more important, because in all these phlegms, it will look like habit constipation. You will not find a transition zone at all. Whereas post 24 hours, if at all you have a retention, you go ahead and do an anorectal manometry. Always rule out an internal sphincter achalasia, because these children will need a rectal myectomy to resolve symptoms. Otherwise, these habit constipation symptoms will not improve with your dietary management or your laxative therapy. And you rule out anatomical abnormalities, rule out a physiological abnormality by taking a barium enema. And in barium enema, your 24-hour retention film is of utmost importance. Whereas in these constipations, sometimes may mislead you. This child was treated for constipation for a period of time, but subsequently had a huge ovarian mass. In fact, it was an ovarian malignancy. So finally, X-rays to show you that there may be huge lesions which are seen outside. This is the newborn with a huge sacrococcygeal teratoma. Huge sacrococcygeal teratoma, which is classically seen clinically. And at the same time, this child had a pain, came to me with antenatal cystic lesion. You took an X-ray. X-ray revealed a presacral soft tissue lesion. All sacrococcygeal teratomas need not present outside like this. There are other varieties of sacrococcygeal teratomas which can have an intra-abdominal component. This is the type 4 sacrococcygeal teratoma. The other ones are type 2 and type 3, which can present to you later. This is again a type 2 and type 3 sacrococcygeal teratoma proved by MRI, but the X-ray revealed a soft tissue lesion. So for completion's sake, the child presented with right hypochondrial pain. Incidentally, X-rays picked up a gallstone. So whenever we have a gallstone, we know we are going to rule out hematological conditions. We are going to rule out any lipid abnormalities. At the same time, any gallstone in a child always rule out a choledochal malformation. So this child had multiple gallstones. We took a MRCP. MRCP revealed a huge cystic lesion in the CBD. Ultimately turned out to be a choledochal cyst, and we did a lab choledochal cyst repair. Hence, finally, to conclude, X-ray is an extension of clinical examination in select cases. Though not confirmatory, it is an added tool. Indication for X-rays and suspicions are top priority. Foreign bodies always remember it is only cautious for a few, natural passage for most. Hernia, we operate on diagnosis, except only for preterm prematurity. Even in these kids, they go on for incarceration, we operate early. Umbilical hernia, don't forget to document obstructive signs. We may need to face litigations later. Any chronic umbilical discharge or abnormal umbilical lesions for a long period of time warrant investigation. If they present with obstruction, confirm underlying pathologies. Anorectal anomaly, a special X-ray such as a cross-prone table Waterloo decides management, hence has to be taken properly. A child not past meconium in the newborn period beyond 24 to 48 hours, and you look for an absent rectal gas shadow on X-ray. Rule out meconium plug, rule out Hirschsprung's disease. Double bubble sign, don't jump into diurnal atresia first. Always have mal rotation higher on the list, because any newborn with bilious vomiting is mal rotation unless put otherwise. NNEC, X-ray, look for pneumoperitoneum and fixed loops. Extreme preterm on CPAP, gastric perforation is always a possibility. Have a close watch. Acute urinary retention, otherwise well child, lure out urethral calculus. Remember to take the X-ray with the penis tilted to one side. Habit constipations, when there are feculomas on X-ray, rule out anatomical and physiological abnormalities. Barium enema, rule out internal sphincter achalasia. elderly child presents to you with bilious vomiting, small bowel pattern on X-ray. When you have ruled out malrotation, which can occur anytime, always rule out intersusception, a band obstruction, and duplication in this order, and proceed for further investigations in this order to catch all investigation. London sign or a patterned aberration presents to you with a delayed radiological evidence. Hence, admit the child whenever you have a patterned aberration. Distended abdomen, look for calcification, look for paucity of bowel gas within the lesion or above the lesion. And X-ray region of interest is mandatory, and always never forget to have a completeness of visualization, because one system can have an abnormality in the other system and it may add valuable details. Sorry for the prolonged session, and thank you one and all for your patient listening.
Dr. Rahul for the wonderful presentation. Both Dr. Nandini and Dr. Rahul, we have enthusiastic, all the audience and all the delegates. It's a wonderful presentation. In fact, it was like revisiting the entire abdominal, the abdomen Pandora was opened, and I think all our delegates would have got benefited, and all the doubts would have got clear actually. And you had a lot of in-depth knowledge of not only pediatric surgery but also pediatric radiology. That's awesome. Thanks both of you for the wonderful presentation. And I hand over the session to Dr. Narmada and for further question and answers, which both the stalwarts are ready to answer. Thank you so much.
Thank you so much, Dr. Amal, for the wonderful. It was really amazing for both the people. They did such a wonderful job of the abdominal X-ray. I'm really now frightened to look at umbilical hernias. I will really go through again and ensure that I document it in the case sheet. So, Dr. Rahul, can you please stop sharing? An amazing presentation and beautifully summarized by Rahul himself. So I don't think any other extra thing is added on here.
Yes.
If anybody is having any doubts, we can just go ahead with the same.
Narmada, there are some questions.
Yeah, there are two questions in the chat box. Yes. Yes, sir. Can I take it?
I think one is Bharati Natarajan. Chronic constipation.
Yeah, you can ask Narmada.
Yeah, chronic constipation treated with lactulose and dilated anal orifice and visible solid fecal matter. Painful on stool decompression in a 3-year-old. What may be the diagnosis?
Usually all painful defecations, invariably most of them will have a fissure. What happens is this fissure, one hard stool will cause fissure in the anorectal ring, and obviously the child will have severe rectal spasm. Once a child has rectal spasm, obviously it will not be amenable for passing the stool subsequently. It will think every time I pass, I'll have severe pain. So usually they go to the wall, stand near the walls and keep their foot folded together and stand there itself. They will try as much as possible not to pass. So treatment first should be to treat the fissure with an Anovate and lignocaine cream. Once the fissure settles down, and then treat the constipation adequately. And in spite of adequate constipation management for a good bowel management program, laxatives and purgatives put together, child has constipation, obviously barium enema would be mandated.
Okay. Thank you so much, Dr. Rahul. I think this is for Nandini madam. How would you proceed if you see a glass foreign body in an X-ray?
Once it is crossed, as Dr. Rahul has mentioned, once you swallow the foreign body and then it is going to come out per via naturalis. It's not going to be a sharp foreign objects creating any perforation of that sort. But the glass pieces, as he has mentioned in one of the burst glass pieces poking into the soft tissues of your peripheries or abdominal wall or anything, you have to obviously go for an exploration and remove the foreign body.
Okay, some radiologists advise only supine X-ray in children. I understand. Is there any condition where you would advise erect X-ray in older children, abdominal X-ray in older children?
Only in cases of blunt trauma. That too, in an adolescent child going for a cricket or a basketball, gets a blunt trauma and comes after 24 hours. As he has clearly mentioned in the named patterns of bruises in the blunt trauma. you have at the end of 24 hours, you will be presenting with some perforation in the duodenum or the stomach, which will show air under the diaphragm in an erect X-ray. Otherwise, we totally bank upon the supine X-rays for our interpretation.
Thank you.
Thank you so much, ma'am. I think we have almost answered the questions in the chat box.
There is one more question, Dr. Narmada. What is the lowest age to diagnose ovarian teratoma?
We have seen even newborn with ovarian teratoma, sir. So there is no young age, sir. We've seen all kinds of children with ovarian teratoma, sir.
Super, right. Okay.
I just have a comment to make. Rahul and Dr. Nandini, thank you. Just one thing regarding the foreign body, especially if you're seeing a long, lengthy foreign, but more than 3 centimeter, more than 1 year, and more than 5 centimeter, more than 5 years, rather than doing a repeat X-ray, the options have to be given to the parents to see, to tell them that there is always a risk of them crossing the D2, D3 loop. So the options has to be given, let them make a decision rather than keep doing an X-ray. That's one thing I would differ because I'm also a pediatric gastroenterologist. That's the reason I'm just telling you that. Other things is fine. The only thing I want to ask you a question is, you did mention of the urethral calculus in a bit, how often do you come across, Dr. Rahul?
I've seen only 2 cases in the last 8 years, sir.
That's one. Thank you very much. Otherwise, I think
and I agree with you, sir. Yes, sir. Obviously, endoscopic removal should be always clearly offered to the kids, sir. Yes.
No, because this area, in this era, you shouldn't be, especially a foreign body of more than 5 centimeter in length or more than 2 centimeter diameter. The options have to be given to the parents. Yeah, thank you, and thank you very much. Fantastic, both of you. Thank you very much.
Okay. I think, there are a lot of take-home points from Madam's thing. I just understood that sacral dysgenesis or sacral agenesis is the first we have to see in an X-ray and look at the vertebra. The abdominal fat, how much can we learn through that? That was an amazing one. The traumatic causes, look at the how to interpret the fluid shadows, look at the solid, when seeing at the solid organs, the kidney, liver and spleen. Also the inflammation of the soft tissues has to be seen, as well as your take on the foreign catheters. Images was also very great, and the radiolucent shadow. Such an amazing variety you had to show the foreign bodies, duplication cyst and congenital diaphragmatic valvulus, hiatus hernia. It was really amazing. Thank you so much, Dr. Nandini Madam, for the wonderful X-rays and your eloquent presentation. I'm very sure this videos will be for everybody to look at, and this particular session will need, even for us who have seen the entire session, to grow through it at least once or twice to understand all the practical points here. And of course, Rahul gave very clear-cut guidance on what to do with the button battery ingestion, foreign body ingestion, because we are constantly asked by the parents. This is one of the very common clinical scenario: when to take a repeat X-ray, when not to take. So that was a very clear one, as well as the difficulty problems with the single magnet and multiple magnet ingestions. And you also made a very important legal point with inguinal hernias and umbilical hernia. Quite often we tell them, it will go away after a year, and then you said that there could be so much of a problems there. And similar to that with the neonatal emergencies, you clearly defined with the no meconium past, looking at the anal orifice, what if you had an anal opening and if you did not have an anal opening, and those with vomiting, with the distended stomach, and of course with the bilious vomiting, and how to differentiate it. We never thought about stones in the children, that we could use an X-ray to differentiate this, as well as the clear clinical take-home points for the calculus, how to valvulus, how to find it out in an X-ray. And this when we often encounter abdominal pain, and we have children with a colicky pain, with a strangury, that was a very how an abdominal X-ray will help us to get the clinical diagnosis at our because sending to an ultrasound when they come in the late night, it might not be possible in tier 2 cities. X-rays will help us there in a large way. So overall, I think it was a very learning points for every one of us who has gathered here, and I'm sure we will be watching this again and again to take home all the points. So Somasundram, for your final words before we close this session.
Yeah, so as you told, it was both the speakers. So it was a mix of both clinical photographs, laparoscopic findings, and X-rays. So it gave us more insights into how you people deal with these things, and how we can like what we have to do such situations. This London sign and all. So
Yes.
it is it's thing which we see in kids, but we often ignore. Oh, nothing will happen. It's only a superficial abrasion and those things. So they are all eye opener to us.
Yes.
And you say that murukku pola motion போறது, that and all are things which we need to go back and ask parents whether constipation, in cases of constipation. So both these are see, really it's new to us. And see, as many people have seen this, and it will be in our YouTube channel for years for people to view and go and revisit. So definitely thank you both the speakers and Dr. Thangavelu sir for picking up these two speakers and to bring benefit to lot of pediatricians. Thank you once again, and see you the next week with the next session, which is, I think it is on miscellaneous, and I think it is by CT and MRI, and miscellaneous by Dr. Gopi and Dr. Venkateshwaran sir. Thank you very much.
Indebted to Dr. Nandini and Dr. Rahul for sharing their cases and the videos.
Yes.
Thank you, madam.
Thank
Our
you.
pleasure.
Thank you, madam. Good night.
Thank you.
Yeah.
Thank you, madam. Thank you, Rahul.
Thank you. Thank you.